Okay, so going over the carbapenems. These are structurally different from penicillin and cephalosporins, and they carry the widest spectrum of activity of the beta-lactam drugs. Epinemum can, can take care of Pseudomonas, which is very hard to kill, by the way. Meropenem can, and these particular antibiotics are bactericidal versus many gram-positive and gram-negative and anaerobic bacteria. They are not inactivated by the bacteria's beta-lactamase, which is good. We have to have those. Your glycopeptides include your vanco and teicoplanin. Both are a very high molecular weight. Glycopeptides have a complex structure. They inhibit cell wall synthesis at a site different than the beta-lactams. All are bactericidal, and they're used for gram-positive infections, not for gram-negative. So vanco is for gram-positive. Let's take a look at vanco. In gram-positive, the drugs enter without any problem because the peptidoglycan does not act as a barrier for the diffusion of these molecules. In gram-negative, however, glycopeptides are of high molecular weight, stopping them from passing through the porins of gram-negative bacteria. So that's why glycoproteins or glycopeptides have no activity against gram-negative. Got to remember how the gram-negative looks compared to the gram-positive bacteria, right? Lipopeptides, daptomycin, it naturally occurring cyclic lipopeptide, and it binds irreversibly to the cytoplasmic membrane, causing membrane depolarization and disruption of the ionic gradient, leading to cell death. It's active against gram-positive organisms. However, gram-negative organisms are resistant. So you can see, excuse me, how important it is when we do blood cultures on patients to determine what we would give them. If we were to start out with a broad spectrum, we wouldn't start out with daptomycin, technically, because if the patient had a gram-negative bacteria, it would be it wouldn't help them. Cycloserine inhibits two enzymes, D-ALA and D-ALA synthetase, and alanine racemase. Racemic drugs are basically those drugs that are almost, their chirality can change. Uh, catalyze wall synthesis inhibits the first stage of peptidoglycan synthesis. The structural analog of D-alanine inhibits synthesis of D-ALA dipeptide. It is the second line drug in the treatment of tuberculosis, which is interesting because usually there's 4 drugs that we use to treat TB. An isoniazide and a thalidomide and ethambutol are one of them. Other cell wall inhibitors, the isonicotinic acid hydrazine, INH, or isoniazide. They inhibit the mycolic acid synthesis. For an unknown reason, it may be the elongation of fatty acids and hydroxylipids that are disrupted. Ethambutol interferes with the synthesis of arabinogalactan in the cell wall. The side effects of these are interesting because ethambutol can affect the eyes. Isoniazid can affect the heme production and cause anemia. Other cell wall inhibitors, bacitracin. Typically, this is given for topical. It is too toxic for systemic use. And it is also it prevents the dephosphorylation of the phospholipid that carries the peptidoglycan subunit across the membrane. So it basically blocks regeneration of the lipid carrier and inhibits cell wall synthesis. Notice, gram-positive bacteria have this huge cell wall, right? I mean, it's what, 10 to 15, maybe more molecules thick. So if we're going to kill that bacteria, the cell wall drugs are the most, we want to break through that cell wall. We want to, stop it from being built, do something to destroy it so that that ions can get in and kill the bacterial cell. Polymyxins, many gram-negative rods, especially Pseudomonas, with positively charged free amino group, like the cationic detergent, they interact with the lipopolysaccharide and phospholipid in the outer membrane, increasing permeability. It can kill gram-negative rods like Pseudomonas, which is interesting. Inhibition of cell membrane function. So polyenes are antifungal. They have to bind to a sterol, which is ergosterol, and change the permeability of the fungal cell membrane. Amphotericin B, also a fungal antibiotic. It binds to ergosterol with a series of 7 unsaturated double bonds in a macrolide ring-like structure. Activity is disseminated mycoses. We call amphotericin amphoterrible because it has so many side effects. Nystatin is a structural analog to amphotericin B, but is only given topical. Azoles, they block cytochrome P450 dependent demethylation of lanosterol and inhibit ergosterol synthesis, such as ketoconazole, fluconazole, itraconazole, miconazole, and chlorotrimazole. We give these for fungal infections. Inhibition of protein synthesis. This binds the ribosomes. It results in failure to initiate protein synthesis, no elongation of the protein, causes a misreading of transfer RNA of the deformed protein. Boom, bacteria dies. I don't know. I'm partial to these inhibition of protein synthesis drugs. I guess because they're so efficacious. So here we have protein synthesis. We have replication. Remember, we have the macrolides that inhibit the 50S, and then we have the aminoglycosides that inhibit the 30S. So here's your replication, your DNA, your messenger RNA, translation of protein synthesis, your ribosome, your protein, and so here it goes. We have DNA, RNA, protein. So the subunits are what the antibiotics break. There's a ribosome amino acid chain, amino acid transfer RNA, large subunit, codon, small subunit. Drugs that act on the 30S, aminoglycosides, streptomycin. Actually, streptomycin was one of the original drugs used for tuberculosis. A mechanism of killing involves attachment to the specific receptor, P12 for streptomycin. It blocks activity of initiation of the peptide formation, so mRNA plus formylmethionine plus transfer RNA, which causes a misreading on the recognition region. Wrong amino acid is inserted, bacteria dies. Tetracyclines work on the 30S ribosomal subunit. Bacteriostatic versus gram-positive and gram-negative bacteria, mycoplasmas, chlamydiae, rickettsiae. They block the amino-acyl transfer RNA from entering the acceptor site and prevent introduction of a new amino acid to the nascent peptide. So we kill the Borrelia burgdorferi rickettsiae with tetracyclines, 30S. And this just goes into the mechanism of action. Tetracycline, minocycline, doxycycline. And it talks about what their indications are, what they kill, contraindicated in renal or hepatic dysfunction, pregnancy or lactation in children under 8. really, with the tetracyclines, giving it to children under 8, their teeth haven't formed yet, it can cause their teeth to turn black. And sometimes their teeth, even when their adult teeth come in, they'll have discoloration. So we avoid that in children. Drugs that act on the 30S subunit, linezolid, interfere with the formation of the initiation complex. They block initiation of protein synthesis. I'm sorry. Activity, vancomycin-resistant enterococci, methicillin-resistant Staph aureus, nasty, nasty bugs, Staph epidermidis, and penicillin-resistant pneumococci. So we really want to hold off giving these are the big guns. Why do I say that? Because if we're too lax and we give big guns too much, what do you think will happen to the bacteria? It'll figure out a way, right? Eventually, it'll figure out a way to block it. So chloramphenicol, remember the gray baby syndrome? We don't give this to babies. It inhibits peptidyl transferase and chain elongation and prevents the synthesis of new peptide bonds, mainly bacteriostatic, for treatment of typhoid fever. Remember what bacteriostatic is, right? It just basically holds the bacteria down while the body can develop its own immune response. 50S, macrolides. So the 50S ribosomal subunit is attacked by your macrolides, your erythromycin, azithromycin, and clarithromycin. The binding site is the 23S ribosomal subunit of the 50S subunit. So basically the mechanism is it interferes with the formation of initiation complex for peptide chain synthesis. It interferes with amino-acyl translocation reactions and prevents the release of uncharged transfer RNA from the donor site after the peptide bond is formed, thereby preventing chain elongation. Drugs that act on the 50S subunit. We have clindamycin. It resembles a macrolide in the binding site. It has antibacterial activity and mode of action. Bacteriostatic versus anaerobes, gram-positive bacteria, Clostridium preferengens, and gram-negative Bacteroides fragilis. Clindamycin is used for skin infections, also like cellulitis. They give it IV. This kind of goes over this table. And we can take a look at this. So this kind of breaks it down. Your clindamycin, it covers everything except enterococcus, mostly community acquired pneumonia, MRSA, and other anaerobes. It inhibits the peptide bond formation of the 50S ribosomal subunit. Adverse effects are pseudomembrane colitis and GI upset. So here's your skin infections, contraindicated in hypersensitivity and infants. Chloramphenicol, gram-positive, gram-negative, and anaerobes. This also inhibits peptidyl transferase action of transfer RNA at the 50S ribosomal subunit. It can cause aplastic anemia and gray baby syndrome, as I mentioned earlier. And linezolid, gram-positive, including vancomycin resistant and MRSA. Binds the 50S ribosome and prevents the functional 70S initiation complex. So, very powerful. These are very powerful drugs. Drugs that act on both 50 and 30. This is cool. These are your gentamicin, tobramycin, natilomycin. Treatment of systemic infections by susceptible gram-negative bacteria, including Pseudomonas and Enterobacteriae. Amikacin, treatment of infection by gram-negative bacteria resistant to other aminoglycosides. Kanamycin has very broad activity, but it doesn't kill Pseudomonas. So as you notice, Pseudomonas keeps raising its ugly head from time to time. And that's because it's a difficult bug to kill. So here's your gentamicin, tobramycin, and amikacin coverage for gram-negative. This includes Pseudomonas, except for kanamycin. Binds the 30S ribosomal subunit, inhibiting protein synthesis. Very nephrotoxic, autotoxic, which is irreversible if we stop the medication. Vestibular toxicity is most important in aminoglycoside toxicity. Contraindications, hearing loss, pre-existing hearing loss, and renal dysfunction. Inhibition of nucleic acid synthesis. So the inhibition of precursor synthesis and inhibits synthesis of essential metabolites for synthesis of the nucleic acid. So para-aminobenzoic acid, here's your sulfonamides through competitive inhibition, dihydrofolic acid synthetase. And this is where your folic acid inhibitors work. Trimethoprim through competitive antagonism. And it works on blocking your thymidine, purines, and methionine. So you can see that these are dangerous drugs to our body's RNA and DNA. So antimetabolites, folate pathway inhibitors, sulfonamides, and trimethoprim sulfamethoxazole. They resemble a microbial substrate that competes with that substrate for limited microbial enzyme activity. So if we look at enzyme substrate, okay, here's your bacterial enzyme. Here's your substrates. Here's your normal enzyme substrate and your end product. Here's the drug, here's the substrate. Notice, competitive antagonism, enzyme drug complex doesn't fit, so there are no products made, and the bacteria is rendered useless. Sulfonamides are a structural analog to para-aminobenzoic acid, precursor of tetrahydrofolate, and inhibits tetrahydrofolate, which is a methyl donor in the synthesis of adenine, guanine, and thymine. Can treat UTIs, otitis media, strep pneumonia, H. influenza, and shigellosis. It's a drug of choice for toxoplasmosis and pneumocystis pneumonia, which you'll find these diseases, these bacterial, this particular bacteria is usually found in HIV patients with CD4 counts lower than 200. We usually treat them with that. And then once their CD4 count goes up, you know, we stop it until it goes back down again and we start it. So TMP SMX, Spectra, Bactrim, gram-positive, Staph aureus, Mos MRSA, gram-negative, enteric, nocardia, pneumocystic jirovecii, and toxoplasmosis. The mechanism of action inhibits the folinic acid pathway. TMP inhibits dihydrofolate reductase, and SMX competes with para-aminobenzoic acid. Adverse effects are hepatitis, Stevens-Johnson syndrome, bone marrow suppression, hyperkalemia. Drug toxicity increases free levels of many other drugs, which means it is an inhibitor. So if you're taking warfarin, the actual warfarin can develop more toxicity in the system and build up and cause, profound bleeding. Stevens-Johnson syndrome is very dangerous because on these antibiotics, it can affect the entire immune system and cause these rupture of vesicles to occur all over the body, and it can be fatal. So it's very dangerous, Stevens-Johnson syndrome. Inhibition of nucleic acid synthesis, trimethoprim inhibits dihydrofolate reductase, which means that we can get an inhibition in purine synthesis, so we can also get vitamin B12 deficiency. It can really knock out our mechanism of action for generating necessary players in, in, in our body and vitamins. Quinolones inhibit DNA synthesis. Your fluoroquinolone, ciprofloxacin, norfloxacin, oxyfloxacin, and all the floxacins are topoisomerase inhibitors involved in DNA replication. They basically relax the DNA spirals or in helixes, but only gyrase, which carries out DNA supercoiling. So they're topoisomerase 2. The main quinolone target is DNA gyrase, which is responsible for cutting one of the chromosome DNA strands at the beginning of the supercoiling. Once they nick it, the DNA no longer becomes efficacious. They form a stable complex with DNA gyrase, inhibiting its activity and preventing repair. Also, metronidazole is an antiprotozoa. It's an anaerobe including C. diff, Trichomonas, and Entoamoeba. It enters into the cell by diffusion across the cell membrane, and then reduction of its nitro group by the bacterial nitroreductase concentration gradient is formed. Influx of the drug comes in, and production of cytotoxic compounds cause breakage and destabilization of host DNA by cytotoxic compounds. RNA synthesis, rifampicin. This is also used for TB. The semi-synthetic derivative of rifamycin B, it binds to the DNA-dependent RNA polymerase and blocks initiation of bacterial RNA synthesis. So this is used in one of the drugs in tuberculosis, an anaerobic gram-positive cocci. Antimycobacterials. Here you go. These are your TB drugs: isoniazid, rifampin, ethambutol, pyrazidamide. And they all do something different. Ethambutol can cause renal failure. It can also affect the eyes. Rifampin can cause jaundice. And isoniazid can cause hepatitis. And pyrazidamide can also be hepatotoxicity, can cause hepatotoxicity. And this just kind of goes over where the protein synthesis is blocked. So here's your toxic metabolites of metronidazole: cell wall, your penicillins, your cephalosporins, your carbapenems, and your glycopeptides. RNA polymerase, here's your rifampin. DNA gyrase and topoisomerase, here's your fluoroquinolones. Protein synthesis, here's your nitrofurantoin. 50S ribosomal subunit, here's your macrolides and linocosamides. 30S ribosomal subunit is your aminoglycosides and tetracyclines. Your folic acid pathway, TMP, SMX, dapsone, sulfonamides, sulfamethoxazole. And here's your mycolic acid pathway, where you have your isoniazid and ethambutol. It's kind of a nice little diagram. I like it. Drug resistance, something we can't stop. Eventually, the drug will find a way, the microorganism will find a way to become resistant. Cross-resistance is due to a particular antibiotic that often results in resistance to another antibiotic, usually a similar class to which the bacteria may have not been exposed. For example, clindamycin and lincomycin. So bacterial resistance, it happens over years, more and more antibiotics are becoming not useful against certain types of bacteria. And, some, the jury's out, but some will say this is because of an overuse of antibiotics, and that's why doctors are so reluctant sometimes to prescribe antibiotics, especially for children. Intrinsic resistance, mutation affecting specific binding protein of the 30S ribosomal subunit, such as streptomycin-resistant M. tuberculosis and streptococcal facialis. This is why one of the reasons streptomycin has been phased out for one of the drugs for TB. Mutation in porin proteins, impaired antibiotic transport into the cell, leads to multiple resistance. So P. aeruginosa, again, Pseudomonas is a very hard, very difficult bug to kill. Mutations in the penicillin binding proteins, such as in treating strep pneumonia, and altered DNA gyrase, such as quinolone-resistant E. coli. Acquired resistance as a whole make it naturally susceptible through mutation and genetic exchange, transformation, transduction, and conjugation. So when the bacteria start to change, methylation of the 23rd S ribosomal RNA in Staph aureus, altered metabolic pathway that bypass the reaction inhibited by the drug, we have sulfonamide resistance. They utilize preformed folic acid instead of extracellular PABA in Staph aureus and Enterobacteria. So it's become a real issue, and and I want you to appreciate, if anything, from this, the seriousness of strains of bacteria becoming more and more virulent. And yeah, so understanding the antibiotic classes, understanding how they work is really important. Um, and it's important that I think the pharmacist and or physician explain the side effects of these particular drugs. So, and understand, whether or not the patient has any pre-existing conditions that could make them susceptible to toxicity of the drugs. So these are, really important, understanding your different classes and the different kinds of antibiotics. Hope you've enjoyed the lecture. See you again.